Good afternoon.
Good afternoon. So Dr. Vargas Pinto is an endocrine surgeon and works in Danbury Hospital and Howard Hospital. She is also a co-director of the endocrine neoplasia program. And last year we had Dr. Vargas Pinto give us an endocrine review, and it's really good. Now, Dr. Vargas Pinto, we have time is really short, so feel free to go ahead. We have time until 1:20.
Thank you very much. Given the time of the day and the fact that this is a pretty not so common topic for everyone, I have a couple of questions and a couple of fill in the blanks. So even if you are the only person answering, I think that might be a little bit more interesting. Let me see.
I can try to make polls and quizzes. We'll see.
We'll see. Okay. It's kind of difficult to do a concise review on endocrine because there's a lot of different topics. But in terms of anatomy, the one thing that I can remember that it's a little bit important is the anatomy of the thyroid gland. This is the first question that I'm gonna ask, and which of the following correctly identifies the blood supply to the thyroid gland? And then you guys can read the answers. There's someone that can tell me anything?
So, see if the right answer.
Oh, this is a
Let's
tricky
create a
one.
poll, actually. I'm sorry.
So this is a tricky one. Actually, and I made it with that intention. The answer is actually E. You are correct. So the superior thyroid artery is derived from the external carotid artery, but the inferior thyroid artery comes from the thyrocervical trunk, which comes from the subclavian artery. So that's just for starters. A little bit more about anatomy. One of the things that it's important is to understand the anatomy of the laryngeal nerves. So we have two nerves, the superior laryngeal nerve and the inferior laryngeal nerve, and which is also known as a recurrent laryngeal nerve. And both of them have different functions, so it's important to understand that because they are at risk during surgery, especially for thyroidectomies. Now, the first question, the inferior nerve or the recurrent laryngeal wraps around which structure on the right side and which structure on the left side? Anyone? I can't really read the chat at the same time. I apologize.
So actually, release the allow to talk function. So if I think the participants can maybe answer the questions directly.
All right. So the inferior nerve wraps around the subclavian artery on the right side. And this is important to understand anatomical variations, which can place this nerve at risk during surgery. And on the left side, it wraps around the aortic arch. The inferior laryngeal nerve innervates all laryngeal muscles except for the cricothyroid muscle. The cricothyroid muscle is innervated by the superior laryngeal nerve. One of the anatomical variations that it's important for this And let me go back to the superior laryngeal nerve. So the function of the superior laryngeal nerve with the innervation of the cricothyroid muscle, it essentially regulates pitch. So it's the quality and the volume of the voice that is mostly managed by this nerve. When you have a non-recurrent laryngeal nerves, meaning that it doesn't wrap around the typical structures, this nerve actually derives directly from the cervical aspect of the vagus nerve. Most commonly, this anatomical variation happens on the right side. It's exceedingly rare that it happens on the left side, but yes, it can happen on the left side. When it happens on the right side, this anatomical variation, it's actually related to an aberrant subclavian artery. And what you will see is very important if you're planning on doing surgery and you have for example, a neck and a chest CT scan, you should always try to look for the course of the subclavian arteries, more importantly, the right subclavian artery. If this artery is seen coursing posterior to the esophagus, is because the takeoff of the artery, it's abnormal. There's no brachiocephalic artery in that patient, so it comes directly off the aortic arch. And when it courses posterior to the esophagus, as the nerve is supposed to wrap around, but it doesn't descend. So it goes straight from the cervical vagus into the laryngeal entry point. This anatomical variation is called the arteria lusoria or lusorium artery. And you have to expect that there will not be a nerve in the tracheoesophageal groove if you're performing the thyroidectomy when you're seeing this. Sometimes radiology will tell you that that is present in their read for the study, but sometimes they don't. All right. Another important topic that I think is cervical nerve injuries. Some of the nerves in the neck are at risk when we perform surgery. It's a little bit debatable which is the nerve that is most commonly injured during operations in the neck. And I have seen that question popped off before. I would think that at least in terms of reportable injuries, that will be the recurrent laryngeal nerve, because by far thyroidectomies are the most common operations. And sometimes, you know, if you are doing a tracheostomy, that could be the case too, although it's a little bit difficult. You could also argue that the most commonly injured is the external branch of the superior laryngeal nerve because it's so superficial and it just runs under the fibers of the cricothyroid muscle. But I haven't really found an answer to that. And I know that someone asked this last year. That would be my best answer. Now, permanent injury to the superior laryngeal nerve, particularly the external branch, is the one that results in isolated voice fatigue and voice projection. And the key to the question is isolated voice fatigue and projection. So these patients will not have a hoarse voice. They will be able to swallow and breathe normally. When there is, like this question number 8, when there is a unilateral permanent injury to the inferior laryngeal nerve or the recurrent laryngeal nerve, this will result in a hoarse voice. And some patients may have difficulty swallowing, in particularly with liquids. The reason why the patients have trouble swallowing is not that much because the vocal cord is paralyzed. The reason for the difficulty swallowing is because the sensation to the laryngeal mucosa, it's pretty much disrupted. There's some sensation to this area that comes from the internal branch of the superior laryngeal nerve, but most of it comes from the recurrent laryngeal nerve itself. So when there is a permanent injury to this, the patients typically have a lot of hyperdynamic and disorganized contractions. And it takes at least 1 or 2 months for that to start to kind of calm down. There's a little bit of remodeling, and then some of the innervation, when it's provided by the internal branch, that tends to get better over time. So most patients won't have a permanent difficulty swallowing when one vocal cord is paralyzed. When both vocal cords are paralyzed, or if there's one that it's completely immobile and the other one is hypomobile, those patients actually can present with dyspnea. And typically it's a dyspnea on exertion. In terms of treatment options for this, I'm not sure how it will be, or if it will ever be asked on the ABSITE, but this is something that comes up on board exams. You need to know like what to do, how to manage these things. Definitely those patients should be referred to a voice specialist when they can do an assessment and determine what will be the best course of action. Sometimes depending on the severity of the difficulty swallowing and also of the severity of the hoarseness or the voice changes, either patients can have a course of voice therapy, which can help them to project better. And also they can have some strategies to help with the swallowing. And that's provided by the speech pathologist. Other times, if there's not much of a difficulty in swallowing, but the problem is the voice projection, and especially the patients that depend on that for a living, then things like a vocal cord injection with a hyaluronic acid filler, that can be considered. This is a absorbable filler, so it is also only a temporary measure, but in general, it lasts between 3 to 6 months. And for most patients, there will be more symptomatic during this period of time. So once that is done, if that is the what we think that will help the patient the most, then they are reevaluated after that time. The challenge with managing these injuries is it all depends on how wide is the airway of the patient. So patients that typically are not very obese, they tend to have less fibroadipose tissue or redundant soft tissues in the neck. And these patients can easily benefit from the vocal cord injections. When you have a patient that is very obese and they have a lot of fibroadipose tissue and a lot of redundant tissues, that actually can reduce the lumen of the airway in the proximal cervical portion. And those patients may not be candidates for vocal cord injections. So they typically tend to have dyspnea also. Then the next question in terms of nerve injuries is related to the neck dissections. During a lateral neck dissection or modified radical neck dissection, one of the things that we typically need to expose is the spinal accessory nerve. Typically, this is a nerve that is at risk during this surgery. And from all the nerves that are exposed during this operation, is the one that is most commonly injured. Injury to the spinal accessory nerve typically manifests in weakness of the trapezius muscle. And you will see that these patients have a problem with elevating the shoulders, retracting, and rotating the scapula. Okay. Next, we're going to talk about a little bit about thyroid nodule workup. This is very high yield. Specifically, we're going to talk about what the next step for these scenarios is. Let's just say we have 30-year-old female who has an incidental 2-centimeter Thyroid 5 nodule on ultrasound. This is an incidental nodule. We don't have any other history from the patient, but assuming that we see the patient, that we obtain a history and physical examination, there is no family history of thyroid cancer, no family history of any other cancers or genetic syndromes that could predispose the patient to cancer. And there's no personal history of radiation. And on the physical examination, except for this palpable thyroid nodule, you don't really seem to notice anything abnormal. So in this particular case, the next step for this will actually be to get a thyroid stimulating hormone level. It will not be to do a biopsy. The reason for this, it can sound counterintuitive, but it's because you need to assess the hormonal status of the patient before committing to ordering a biopsy. Why? Because a lot of times this could also be an autonomous nodule. If you have an autonomous nodule or a toxic nodule, very frequently it looks like a Thyroid 5 nodule. So just because it's a Thyroid 5 nodule, yes, we do consider it a higher risk for malignancy, but it does not necessarily mean that it is a malignant nodule. So once you obtain the TSH level, that can actually direct your next step. In this particular case, if the patient was hyperthyroid or it had a suppressed TSH, that will actually change your next step. So you will proceed to first work up the hyperthyroidism, and then once you have done that, you will do the biopsy to exclude malignancy. So for that particular scenario, after you have done the TSH level, if it's suppressed, then the next step will be to actually obtain a thyroid scintigraphy or a thyroid uptake scan with iodine 123. If you see that that nodule has high avidity on the scan, you know it's an autonomous nodule. So you have two options for that. Sometimes if the hormonal status is not adequate or controlled for you to, you could consider a lobectomy for treatment, or you can do medical therapy with methimazole. A lot of times the medical therapy will actually become first line. And once you have those hormones stabilized, then you can consider a biopsy. That will be the safest thing to do for the patient. And depending on the results of the biopsy, then that's how you're going to continue to work up the patient or offered an operation if it's indicated. If we take out the second scenario, which is an incidental 4-centimeter thyroid nodule, and you already know that this patient's hormonal status, it's normal. So we do know that the characteristic that correlates more with risk of malignancy in thyroid nodules is actually the size of the nodule, particularly larger nodules, 4 centimeters or larger. So for this particular patient, the next step will actually be a fine needle aspiration biopsy. We typically don't do core needle biopsies for thyroid nodules. In general, it's not necessary. The FNAs are actually, they provide 97% of an accurate diagnosis. And they can also provide sampling for molecular testing if this is needed. The only times in which you would consider a core needle biopsy is, for example, if you needed additional tissue. If for some reason you suspected that this was an intrathyroidal lymphoma, which sometimes you can see on patients who have Hashimoto's thyroiditis, for example, then you should consider a core needle rather than an FNA. On the next scenario, if we have on an FNA, so in the Bethesda category system, if you have a Bethesda 1, that means that your sample was insufficient. So typically, in the absence of a diagnosis, you have the option of repeating that biopsy to see if you can reach a diagnosis. Most endocrine surgeons, if you attempt 2 or 3 biopsies and you are unsuccessful, that's the point where we will offer a diagnostic lobectomy. You can either do that, or you can also do active surveillance, which I do quite a bit. If it doesn't look like the nodule has a gross appearance of malignancy. And depending on the behavior of the nodule, then you can decide if you're gonna offer a diagnostic lobectomy or not. This is something that you need to discuss with the patients. Not everybody it's a candidate for active surveillance, because a lot of times patients are actually very anxious because they don't know what that nodule is. They don't know if you're just watching a cancer, and a lot of times they will decline that. So we tend to offer diagnostic lobectomies a little bit more for that reason, but the conversation should be had for both, truly. Benign thyroid nodules. Benign thyroid nodules, if you have an FNA, you can just monitor that nodule if the nodule is benign. A truly benign thyroid nodule will be stable. It will not change in size. It will not change in appearance. So you could choose to repeat an ultrasound in a year and just confirm that that behavior is fine. If you're just watching a nodule, most of the time you don't really need to do anything else. But in real life, a lot of times, again, patients have anxiety and they just prefer someone to watch it to make sure that that is true. Now, I have said that the biopsies are in general 97% accurate, but they're sometimes when I've had patients who've had multiple biopsies, which are benign. And the reason why I monitor those patients is because at some point, if you have a follicular tumor that has been misdiagnosed as a benign nodule, that nodule will start to change and it will also start to grow. Unfortunately, for follicular nodules, they can look very similar to a benign hyperplastic nodule. And sometimes the only way to tell is actually after surgery. And that has happened several times to me this year, that I have offered a diagnostic lobectomy for a nodule that the clinical pattern is discordant with the biopsy. And then later on, it's a low-grade follicular carcinoma or a papillary thyroid cancer follicular variant. So I do believe that it's important to kind of keep an eye on those two. Bethesda 3, it's usually an indeterminate nodule. Same thing for Bethesda 4. These nodules, they have some atypical cells, but they don't have any other characteristics that suggest malignancy. So for these nodules, most commonly, the next step will be to do molecular tumor profiling. From the same FNA, if you are in a hospital setting or closer to a hospital setting, you can get another sample in the same biopsy and just freeze it for molecular testing. And if you need it, because if it's a Bethesda 3 or 4, then you can just take that sample and send it out. And that actually saves the patient another biopsy. That's one option. The second option is if there's no molecular testing or genetic testing and the answers that are listed, it will be to offer a diagnostic lobectomy. Either approach is very reasonable because in both instances, you're just trying to establish a diagnosis. A lot of times the Bethesda 3 nodules have proven to have a higher malignancy rate than what was previously reported in the literature. So I tend to send molecular testing for all of those. And if the patient doesn't want to do the molecular testing or cannot afford molecular testing, because this is another setting that you will see, sometimes I offer a diagnostic lobectomy, providing that they don't have any other nodules, because their copayment for the surgery is actually less than what they will need to pay for the molecular testing, even with the companies subsidizing a portion of it. So everything will depend on what the circumstances are. But in general, molecular testing for diagnostic lobectomy. For Bethesda 4 nodules, these are typically, you can see Hürthle cells on these nodules. So the reason why you can go straight for diagnostic lobectomy is because, yes, this could be a hyperplastic nodule on someone who has early Hashimoto's thyroiditis. So all that you see are the Hürthle cells. But a lot of times the pathologist will tell you if these are big clusters of cells. And if this is the case, you have to suspect that this is a neoplasm. Those could be either benign or they could be malignant. The only way to reliably diagnose that is actually with surgical resection. Why? Because the diagnosis of follicular or Hürthle cell tumors, it relies on capsular invasion and vascular invasion. And none of those you can see, unfortunately, on cells that are aspirated on a biopsy. How does the molecular tumor profiling help you in this case? Well, the reason is because the most common abnormality that you will see in malignant follicular tumors is actually alterations to the DNA or copy number alterations. So if you have a Bethesda 4 that comes back, don't expect that you're going to have any identifiable mutations, because most likely you won't. You may have RAS mutations. Those are considered intermediate risk for malignancy. Most of the time, those are either carcinomas in situs or the NIFTPs, or they are follicular adenomas. But when you see alterations in DNA copy numbers, that's usually a follicular cancer. And those tends to be a little bit more aggressive. So if you see that, then you should probably offer the patient a total thyroidectomy rather than a lobectomy for that nodule. Okay, and that brings us to our next one. You have a thyroid nodule with a Bethesda 6 pathology. So that means that is thyroid cancer. Bethesda 5 is highly suspicious for thyroid cancer. So in practice, you have two options for the Bethesda 5 too. Some people order genetic testing for that or the molecular tumor profiling. In reality, the risk for cancer, it exceeds 75%. So you are fine if you treat a Bethesda 5 nodule as if it was a thyroid cancer, because in every single instance that I've operated on those, except for one, all of them have been cancers. So in Bethesda 6, we know that the treatment for thyroid cancer is actually surgery. Fortunately, it's one of those cancers that we can still treat surgically. So in this case, if you have a person that has a thyroid cancer, has no family history of thyroid cancer, particularly in a first-degree relative, and that person does not have a personal history of radiation, particularly to the head or the neck, or they have not lived near a power plant or something like that. In general, depending on the size of the nodule and other criteria, those patients may be adequately treated with a lobectomy or a partial thyroidectomy. This was a change that happened in 2015 guidelines, and the new revision is maintaining that. So which approach will be based on the risk stratification for recurrence for that particular cancer. So if you have something that's considered a low risk for recurrence, that can be treated with a lobectomy. If you have something that's considered high risk for recurrence, that should be treated with a total thyroidectomy, even if it's a small nodule. The problem is the intermediate risk. So intermediate risk, you could do a lobectomy or you could do a total thyroidectomy. Now, the first one, if you have a cancer that it's a microcarcinoma, less than 1 centimeter, it's an isolated nodule, there's no abnormal cervical lymph nodes, and there's no additional nodules, that's adequately treated with a lobectomy. There are microcarcinomas which are aggressive, particularly if they have a BRAF B600E mutation. Those needs to be treated, even though they're small, with a total thyroidectomy. If you have a nodule that is between 1 and 4 centimeters, isolated, no abnormal cervical lymph nodes, that can also, it's amenable for a lobectomy as initial extent of surgery. If the nodule is larger than 4 centimeters, even if it's just an isolated nodule and there's no abnormal lymph nodes, you could either do a lobectomy, but most surgeons will actually do a total thyroidectomy because the risk for malignancy or an aggressive variant, it goes higher with size. So those are the criteria for candidates for thyroidectomy, partial thyroidectomy. Now, indications for total thyroidectomy. Any well-differentiated thyroid cancer, which includes papillary thyroid cancer, follicular variant, or follicular thyroid cancer. If they're confined to the thyroid, or if there is regional disease, meaning there is abnormal lymph nodes in the central neck compartment, or if you see abnormal lymph nodes in the lateral neck compartment. Always, if there's an enlarged lymph node or an abnormal lymph node before committing to a surgical plan, biopsy that nodule, that lymph node. And you can do that with an FNA. And you can send the FNA for a thyroglobulin washout. And what that does is it will measure the thyroglobulin content in that lymph node. Even if it's enlarged, but it doesn't look grossly abnormal, if your thyroglobulin level is elevated, that is biopsy-proven metastatic disease. So that patient would also need an appropriate lymphadenectomy, either in the central neck compartment or the central and the lateral neck compartment. So it's always important to biopsy those lymph nodes. Medullary thyroid cancer, it's a little bit different. This is not a cancer that we offer partial thyroidectomies for treatment. It is usually a total thyroidectomy, and most of the time, these cancers tend to have a higher risk of metastatic disease in the cervical lymph nodes at presentation. So a lot of times you will need to perform a central neck dissection, either for therapeutic purposes or for staging purposes. So a lot of times the minimum extent of surgery that you will do for this, it'll be a total with a central neck dissection. For medullary thyroid cancer, it's very important. You need to evaluate the tumor markers. So you need to get your calcitonin levels, you need to get your CEA levels. The calcitonin and the CEA levels have prognostic value. And also for staging purposes. If you have a calcitonin level that it's elevated, you have metastatic disease, even if it's just the cervical lymph nodes in the central neck. And if you have CEA levels that are elevated, those tumors tend to have a little bit of a worse prognosis. For medullary thyroid cancer, your staging should include evaluating the chest and also evaluating the abdomen, because it tends to have liver metastases, especially if your tumor markers are through the roof. So you will need a chest CT scan and preferably an abdomen MRI to look at the liver. Hurtha cell neoplasm with positive mutational profile. I already talked a little bit about this. That's a total thyroidectomy if it has high copy number DNA alterations. Microcarcinomas with additional nodules, even if they don't have enlarged lymph nodes, because you can have multifocal disease. And most of the time, the satellite lesions are very small. So you may be able to just see in one, but when you remove the actual gland, you will see that there's multiple ones. Poorly differentiated thyroid cancer, and also in anaplastic thyroid cancer, there is a very limited role for surgery as treatment. The treatment for anaplastic thyroid cancer is actually multimodal therapy, and it depends on this staging. Every anaplastic thyroid cancer is stage 4, but we have 3 stages. We have stage 4A, stage 4B, and stage 4C. Stage 4Cs are completely unresectable, and they usually have distant metastatic disease. So those will be treated with chemoradiation. Stage 4A, which is really very, very rare, is when you have an anaplastic tumor that is actually confined to the thyroid gland and maybe to only the lymph nodes that are in the central neck compartment. If that is the case, then total thyroidectomy with central neck dissection, it's indicated, followed by adjuvant therapies, which will probably be depending on the mutational status. You will want to know if they have a BRAF mutation that you can treat. There's also RAS mutations, PLD1 mutations that you can treat with checkpoint inhibitors too. So depending on the mutational profile of that tumor, once it's resected, that will be the adjuvant therapy. And that's stage 4A. Stage 4B is actually tumors that are not at the present time resectable, but could be if the therapies work. So those, it will go to chemotherapy and radiation. And if the tumor, for whatever reason, responds, because we know that the prognosis for these tumors is terrible, but if it responds, then surgery may have a role in controlling local disease and continuing additional therapies. Other than treating cancer, there's other indications for total thyroidectomy. I think the most common one and the most important one is actually for the treatment of hyperthyroidism, for Graves' disease, that it is refractory to medical treatment, or patients who have had adverse reactions to methimazole and PTU, or patients who have had that but are not candidates for radioactive iodine ablation. Those include pregnant women, heavy smokers, and patients with moderate or severe thyroid eye disease. So the radioactive iodine can actually exacerbate thyroid eye disease symptoms. So those patients, they will not be a candidate for RAI. They will come to you for thyroidectomy. Same thing with the smokers, because the respiratory symptoms can become worse. They will come to you. And also the pregnant females or younger females that are looking to conceive soon enough, or that their partners are also looking to, have a baby. A lot of the young men will actually opt for thyroidectomy rather than having radioactive iodine, because there is a risk of infertility with these treatments, and people don't want to assume that risk. And I'm going to try to speed up. Okay. So going back after thyroidectomy for thyroid cancer, we know that the low-risk tumors, which are tumors that are smaller than 4 centimeters, they don't have any lymphadenopathy, there's no other nodules there, there's no family history or history of radiation, those can be treated with a lobectomy. We have the high-risk tumors, which are listed on the left. These include, regardless of the size, nodules that seem to have gross extrathyroidal extension, either into the trachea, the esophagus, the parathyroidal, fibroadipose tissue, or the recurrent laryngeal nerve itself. The risk of recurrence for that is actually close to 40%. So absolutely, those patients will need a total thyroidectomy and will need adjuvant radioactive iodine. If you happen to have incomplete tumor resection, you thought it was resectable, but for some reason, when you're performing the operation, there was a small amount of tumor that could not be removed. This can happen when you have larger tumors and they are located at the insertion of the recurrent laryngeal nerve into the larynx. Like sometimes people leave, it's either that or just transecting the nerve. So sometimes that can happen. If you have a lymph node that has biopsy-proven cancer and it's larger than 3 centimeters, if you have a follicular cancer with extensive vascular invasion, because the spread in these tumors is actually hematogenous, it's not really lymphatic. So in order to reduce the risk of recurrence or in the future, in the lungs, most likely, or in the bones, you have to do the radioactive iodine. In terms of molecular tumor profilings, TERT mutations have a bad prognosis in thyroid cancer. These tumors are very aggressive and usually they have high recurrence rates. And if you happen to have a TERT mutation coupled with a BRAF V600E mutation, that's probably one of the worst mutational tumor profiles that we have. Those tumors need to be treated very aggressively. So it's an R0 resection followed by radioactive iodine therapy. The problem with those tumors too, and it's the same with the follicular carcinomas, with time, they can lose their avidity to radioactive iodine. So you may only be able to give that treatment once. If that happens and the tumor can either differentiate or doesn't take radioactive iodine anymore, there are some protocols with chemotherapies to try to re-induce the avidity. And then once you have done that, try to see if it will take iodine, and maybe you could do that again. But if that is not the case and the tumor still does not take up iodine, then you will have to go to second-line therapies. And most of the time, those are tyrosine kinase inhibitors. The intermediate risk are the ones that can go either way. So the treatment of these tumors is actually at the discretion of, I think this should be a joint decision between the surgeon and the endocrinologist, but it's actually the endocrinologist's final decision in what they're going to do. Aggressive variants like the tall cell and the sclerosing, they're only diagnosed after you have performed the surgery. So in those instances, because the risk of recurrence is somewhere between 15 to 30%, closer to the 30%, many endocrinologists will decide to do the adjuvant RAI. Microscopic extrathyroidal extension is something that's also highly debated. Some people will do a low dose of radioactive iodine, 30 millicuries, to try to ablate whatever disease is there. And then you can monitor those patients with thyroglobulin levels and thyroid ultrasounds for structural disease. If you have a papillary thyroid cancer that has extensive vascular invasion, or if you have a PTC that has a BRAF V600E mutation, but that tumor is confined to the thyroid, that's intermediate risk. If that tumor has some extrathyroidal extension, that's considered high risk with a BRAF mutation only, and that will need radioactive iodine. And if you have more than 5 lymph nodes involved. If you happen to have a patient that you do a complete resection and 3 or 4 lymph nodes are actually positive, a lot of times what you will do is you will perform active surveillance with thyroglobulin levels. And if the thyroglobulin levels are elevated, that is considered biochemically incomplete disease. So you will tend to suppress the TSH, and you will do a neck ultrasound as a baseline to see if you have any structural disease. If you have structural disease, meaning you find something on the ultrasound, then that patient will come back to you for a reoperative treatment. But if there's no structural disease, then you can monitor that patient until structural disease is found, and then you can treat them surgically again. Quick note on MEN syndromes. We know that these are the most common or commonly known syndromes that involve tumors in the thyroid and the parathyroid glands. For MEN1, which includes a person that can develop pituitary adenomas, parathyroid tumors are usually hyperplastic, meaning that even if, and this can be synchronous or metachronous, you can have someone that has a single parathyroid adenoma in MEN1, but like for sure, they will continue to develop tumors because the defect causes hyperplasia. And you can have also the pancreatic tumors. The important point here is that a lot of times these patients will present with primary hyperparathyroidism. And the correct extent of surgery for these patients with MEN1, it should be a subtotal parathyroidectomy. So that being said, sometimes if the patients have only one gland that they can see, they may choose not to have a subtotal parathyroidectomy, and they may choose for you to just remove that one gland. I have been in those situations, and I have advised of subtotal parathyroidectomy for definitive treatment, but sometimes they refuse and you just need to treat them somehow. So I have done single adenoma removals for those patients, but I tell them you have to continue to monitor the calcium level because this will come back and you will need another operation. So MEN type 2, there's 2 more common presentations. So type 2A is the more common of the 2. These patients typically have parathyroid tumors, medullary thyroid cancer, and pheochromocytomas. The highlights of this is parathyroid tumors usually present first, usually, not always, but most commonly, that's the initial presentation of this syndrome. If the patients are diagnosed with a pheochromocytoma and another tumor, either a pheo and the medullary thyroid cancer, the adrenalectomy for the pheo should be performed first, and then the medullary thyroid cancer should be treated. Of course, I know you all know that. And the type 2B is a little bit less common. These patients too have medullary thyroid carcinomas and pheochromocytomas. The penetrance for those phenotypes in these 2 syndromes is quite high. So almost all of them, depending on the mutation, specifically if you have a RET mutation on the 228 gene, it's a very high penetrance for medullary thyroid cancer, more than pheo in type 2A. But in type 2B, you will also have the MTC and the pheo with high penetration. So at some point, they will get it. Hyperparathyroidism. So we tend to think about parathyroid disease in terms of 2 diseases. There's also tertiary hyperparathyroidism, which surgery has a role in it. Primary hyperparathyroidism is your typical parathyroid adenoma. We all know that the treatment for that is parathyroidectomy. When is parathyroidectomy indicated? Heavily debated sometimes. Any patient who is diagnosed under age 50, doesn't matter if it has symptoms or not symptoms or end organ damage, or it doesn't matter. They have an indication for parathyroidectomy because they're still, in the case of women, they're still developing some of their bone mass, and they still have so many years to live that there is no benefit on waiting until there's symptoms for the disease. So we do it as a preventive measurement. Patients that have a calcium level that is higher than 1 milligram over deciliter over the upper limit of normal. And then in terms of symptoms, there's the bone pains, there's the constipation, the abdominal pain. Some people can have exacerbation in their reflux symptoms that is not controlled with adequate acid suppressive therapy. There's neurocognitive symptoms. The most predominant is a lack of attention, or they will describe it, our concentration, as a mental fogginess. And that's one of the symptoms that tends to improve the most after the surgery. Women with osteopenia, osteoporosis, and women who have had vertebral fractures from those. Those are symptomatic cases. Other patients that may not be symptomatic, but there's criteria for surgery, is hypercalciuria diagnosed on a 24-hour urine collection, typically a level of more than 250 in women and 300 in men. This has changed. It used to be 400, but a lot of times by the time that the hypercalciuria reaches that level, people already have silent kidney stones, or they have had a kidney stones. So we're moving into trying to perform the operation sooner to reduce morbidity. Secondary hyperparathyroidism. This is your typical patient on dialysis who has hyperparathyroidism. Very important. The first line of therapy, it's medical. So it will be the nephrologist issue until it becomes unmanageable. Usually the treatment consists in vitamin D analogs, phosphate binders, the actual dialysis treatments, and also calcium carbonate. It's important to note that these patients typically have either normal calcium level or low normal calcium level. So this might be a patient with a PTH of 1,000, but the calcium level, it's probably 8.4. Surgery is indicated when typically the hyperphosphatemia becomes unmanageable despite maximal therapy. If the patient has skin lesions, which calciphylaxis, that's another indication. And then the other indication is if this patient is a kidney transplantation candidate, you should perform the parathyroidectomy first if the levels are above 600, because that can carry a higher risk for graft thrombosis and failure. So it's preferable to do the parathyroidectomy first in that case. And what you're going to be performing, it's either, there's two choices. There's the subtotal parathyroidectomy, in which you will remove 3.5 of the glands. So you will leave half of the gland with a vascular pedicle inside. The benefit of this is the hypocalcemia is less for the patient, and it's a shorter hospital stay. Versus if you do a total parathyroidectomy with an autotransplantation, sometimes people do it in the forearms, or those patients tend to be on high doses of calcium and calcium baths for a very long period of time, meaning months, because of the hypocalcemia. And then the problem is some of those implants may fail and not develop at all. So you can end up with someone with hypoparathyroidism for a longer time. Very quickly in the last 5 minutes or 4 minutes, incidental adrenal nodules. This is something that is absolutely very common in any general surgeon's practice. You do a scan, there's an MVA, trauma, I don't know, activation, and you found an adrenal nodule. Any adrenal nodule which has less than 10 Hounsfield units in unenhanced cross-sectional imaging, meaning no contrast, less than 10, that's a lipid-rich adenoma. You can say that with over 95% confidence. So you can diagnose this with a plain CT scan that has no contrast. If the Hounsfield units fall between 10 and 20, that could still be an adenoma, but this is most commonly what we call the lipid poor adenoma. And the reason is their fat content is less. So the appearance, it's a little bit different from the lipid rich. For these ones, you will either need to do an MRI, or you will need to do a CT scan of the abdomen to calculate the washouts. So any lesion with those Hounsfield units and more, and an absolute washout over 60% and a relative washout, over 40%, those are adenomas. Pheochromocytomas, they tend to have very high Hounsfield units, could be like 90, 100. They look very heterogeneous, and on the arterial face, they look super bright. Adrenocortical carcinoma can look like anything. There is no particular radiographic pattern for ACC. It could look like a lipid-rich adenoma, or it could look like a pheochromocytoma. The important thing is that these nodules will grow rapidly over time. So when you have a mass that it's indeterminate, you need, and this is the index study, you need to do an interval or follow-up study, either 3 or 6 months later, because you need to assess the rate of growth. Typically, the only thing that you may be able to see if you're suspecting it's an ACC is that there might be some evidence that that nodule has some extra adrenal invasion, or it's invading the adjacent organs, or you may see some retroperitoneal lymphadenopathy. That's not really very common. Most commonly, these are diagnosed when they're very large lesions. In an indeterminate mass is anything over 20 Hounsfield units. It's specifically if when you do the CAT scan, the washouts do not correlate with an adenoma. Those indeterminate masses, if it's 4 centimeters or larger, they need adrenalectomy. If they're less than 4 centimeters, you can monitor them for growth, because a lot of times they can be hematomas, or they can be adrenal cysts that have a hemorrhagic component. So it does not necessarily mean it's an ACC, but if they start to grow, adrenalectomy. Adrenocortical carcinoma, the treatment is complete surgical resection. We know that this has a poor prognosis and the recurrence is very high. So the best answer is to perform an open adrenalectomy. Why? Because you may have unrecognized advanced local disease, and you may need to perform a multivisceral resection. So you're better served with just doing an open adrenalectomy and removing anything else that is touching the tumor and block with this specimen. The only thing that we know, because the tumor profiles for these tumors, unfortunately, are not necessarily predictive of prognosis, but we do know that if there is a high Ki-67 index, those are high risk for recurrence. Those should have mid-obtain. And the worst prognosis are the ones who produce cortisol and the androgens. And thank you very much for having me. There's 1 minute for a question if you have one.
Awesome. Thank you.
Good luck on the ABSITE.